So the next thing in the glaucoma is POAG and PACG. Okay, POAG, that is primary open angle glaucoma. So beginning up with primary open angle glaucoma. Open angle glaucoma, we have studied this before also, now in a great detail. Very simple. Now, primary open angle glaucoma is also known as chronic simple glaucoma. Okay, chronic, the word itself tell us that it will be for a long time of duration, like it will occur after more than 50 years of age. Okay, that is the most common age for primary open angle glaucoma or chronic simple glaucoma. It is bilateral and it is symmetrical. Okay, the family history, it is also hereditary type. Okay, associated with genes. So what are the genes associated in the family history? These are optineurin, MYOC and WDR36. These are the gene associated with primary open angle glaucoma. What are the symptoms associated with primary open angle glaucoma? Most commonly headache and delayed dark adaptation. Okay, this is the symptom of primary open angle glaucoma, delayed dark adaptation. Another symptom, that is frequent change in presbyopic glasses. Okay, so there is a frequent change in your glasses which are presbyopic glasses. Obviously after the age of 50 the patient is going to suffer with presbyopia, so frequently those presbyopic glasses would be changing. Okay, what are the signs of primary open angle glaucoma? The signs are intraocular pressure, that is more than 21 mmHg. Okay, and more than 5 mmHg differs between both the eyes. Okay, so the intraocular pressure would be more in one eye and the another eye. Okay, so even the intraocular pressure is within the normal limit, but then too it is differing from both the eyes. Okay, now it could be more than 8 mmHg, differing in diurnal variation. Okay, so this is in diurnal variation. Now the optic disc signs in the primary in your primary open angle glaucoma. What are the optic disc changes? So there is a loss of neuroretinal rim. So the rim which you see at the posterior aspect, that rim is lost. So this is the optic disc sign. Now initially it is affected at the inferior temporal site. Okay, and this is NRR called, this is called as the polar notching. Okay, this is called as the polar notching, but later the nasal NNR is also affected. Okay, then the optic disc signs are ventral cupping is seen. Okay, so ventral cupping is also seen. Let's see an image. So here you can see the disc and the cup, and this is the normal image, but here the cup has been expanded. Okay, and this is the your outer disc. Okay, so here the cup has been expanded and this is ventral cupping. Now what are the other signs of primary open angle glaucoma? This includes laminar dot sign. Okay, so you can see laminar dot sign over here, and that is the fenestrations of the sclera, and these are visible grayish white dots. Okay, so on the sclera the person would be he will be seeing grayish whitish dots. Okay, because there are fenestrations on the sclera. Okay, now the splitted hemorrhages is seen on the optic disc surface. Okay, so first there was fenestrations on the sclera, the second you can see splitted hemorrhages on the optic surface. The third sign that you can see is called as the bionetic sign. Okay, this is nothing but double coagulation of the blood vessel. Okay, now how does bionetic sign looks like? So this, it is going to look like this bionetic sign. That this was the normal blood vessel, it was going like that, but in bionetic sign it is going like this. Okay, this image clearly tells you about this bionetic sign. Okay, moving on. So now what are the visual field changes associated? So these are, firstly, the patient would be suffering from the earliest visual field defect, that is isotoper constriction. Okay, so it will suffer for isotoper constriction. Then there would be a bearing of the blind spot. Okay, there would be a bearing on the blind spot. It could be due to a paracentral scotoma, as you can see over here. Para means around the center, so the scotoma will be around this center. It could be Siddle scotoma, also called as sickle shaped. Okay, so you can see a sickle shaped scotoma over here, and it is also paracentral. Okay, or it could be arcuate Bajram scotoma. Okay, it could be a arcuate shaped badged scotoma, or it could be a double arcate ring scotoma. Okay, both the side it is forming a ring, and this leads to step defect. Okay, but the unequal, so step defects are basically, you can see in this image, the upper curvature, the upper curved part, that is little smaller, and the lower one is a little greater, so there could be a unequal contraction. Okay, basically this will lead to unequal contraction, and there would be a step defect due to this, and this step defect is of two types, that is central and Ronen's peripheral step defect. Okay, and this will lead to loss of central visual field. Okay, so the central visual field would be lost. After that, later it will affect the temporal visual field also. So first the central visual field will be lost, and then the temporal visual field will also be lost. Now what is the treatment for primary open angle glaucoma? Okay, so we are going to basically give PGF2 alpha agonist. Okay, so the route of administration would be topical route, obviously, and we are going to give PGF2 agonist. These are the drug of choice. Now what are the examples? So latanoprost, this is the drug of choice in this case, and bimatroprost. So latanoprost and bimatroprost, these are the two drugs which are PGF2 agonists. Now what is the mechanism of action of these agonists? They increase the uvoscleral outflow. Okay, they increase the uvoscleral outflow, and the dosing is OD dosing at 9 p.m. Okay, there is an once dose for 9 p.m. So that is why they are the drug of choice. Now what are the ocular side effects associated with these drugs? PGF2 agonists, these are hyperpigmentation of iris and hypertrichosis, that is growth of the eyelashes, and that is why it is also used in hypotrichosis. Okay, this drug is also used in hypotrichosis because its side effects is growth of eyelashes. It could also lead to uveitis as a side effect. It can also lead to cystoid macular edema and reactivation of the hepatic kernictis. Okay, that is the most important one. Reactivation of the hepatic kernictis is a side effect for these drugs. Now what are the medical treatments for POA AG. These were the only symptomatic treatments. Now we have to treat it medically also. So we can give timolol as a BD dosing, or we can give betoxolol. Okay. The mechanism of action would be decreased aqueous secretion. So this is the mechanism of action and this is the medical treatment. What are the side effects associated with these both? These are blepharoconjunctivitis, NLD blockage, corneal anaesthesis, and betoxolol is associated with, particularly betoxolol is associated with aphakic CME. Okay. Now what are the contraindications of these both? The mnemonic is A, B, C, and D. Arrhythmia, bronchospasm, chronic renal failure, diabetes. These are the contraindications for these all drugs. These were basically beta blockers which we were using as a medical treatment. Now some alpha blockers used as in medical treatment. So these are aproclonidine and brominidine. Okay, these are the two drugs, aproclonidine and brominidine. The aproclonidine, the mechanism of action is it decreases the aqueous secretion and it increases the trabecular outflow. What are the side effects associated with aproclonidine? These are follicular conjunctivitis, okay, conjunctivitis and mydriasis. There could be eyelid retraction also. So these are the ocular side effect associated with aproclonidine. Now buprenorphine, the mechanism of action is simply it decreases aqueous secretion. What are the ocular side effects and contraindications for this? So contraindications are drowsiness, depression, apnea and bradycardia. These are the contraindications for bromonidine. Okay. Now the medical treatment, it varies from age to age. That is why carbonic anhydride inhibitors are used. For example, acetazolamide. Okay, so acetazolamide, this is not given topically. Remember this. Now brinzolamide and dorzolamide. So dorzolamide is given in children's basically. Remember this. Dorzolamide is given in children as a medical treatment for POAG. Okay. Now, what are the contraindications in sulfa allergy? So these carbonic anhydride inhibitors are contraindicated in sulfa allergies. Now, what are the new drugs associated for the treatment of primary open-angle glaucoma? These are nitric oxide donating prostaglandin analogs. Okay, for example, latinoprostan burot. Okay, latinoprostan bunot, and this is administered in an broken into. So after administration of latinoprostan bunot, it is broken inside the body into two, that is latinoprost and butadienol. Okay, so latinoprost, it increases the uvoscleral flow, and bunodienol, it donates no nitric oxide. Okay, and it releases the trabecular meshwork. Okay, so these are the two functions. Another category in new drugs except nitric oxide donating prostaglandin analog, these are rho kinase inhibitor. Okay, rho kinase inhibitors such as nitarsodil. Okay, rho kinase inhibitors such as nitarsodil, very important. The mechanism of action is decreased aqueous production. Same. Now this decreased aqueous production is by inhibiting non-epinephrine transport. Okay, by inhibiting non-epinephrine transport and increasing the trabecular outflow by promoting actin. Increasing trabecular outflow by promoting actin, and there would be a myosin contraction over here. What is the side effect for Rho kinase inhibitor? They cause corneal verticillate. Okay, now that was the treatment. The surgical treatment for primary open angle glaucoma, this is laser trabeculoplasty, okay, LT, and this is of two types, ALT and SLT. The ALT is nothing but argon LT, okay, laser trabeculotomy. So argon laser trabeculotomy, and this is by 110 nanometer. The SLT is nothing but selective laser trabeculotomy, and this is selective laser. Okay, it is selective for the laser and it is applied to pigmented trabecular meshwork. Okay, so that is done only on the pigmented trabecular meshwork only. Okay, now the laser used in selective laser trabeculotomy, trabeculoplasty, that is frequency double ND yak laser. Okay, so frequency double ND yak laser, which has a frequency of 532 nanometers, that is used in your selective LT. Okay, now the mechanism of action of both the argon and the ND is YAG laser is photocoagulation. So it acts by the photocoagulation. No, the SLT is the treatment of choice. Very important. It is the treatment of choice for the prophylaxis of other eyes also. So another type, that is trabeculectomy. So we can do trabeculectomy as a surgical option. So in which the fistula is created between the anterior chamber and the subtenon space. Okay. Now the most common cause of failure of trabeculectomy is fibrosis of the fistula, and to prevent this fibrosis we used anti-metabolites. Okay, we use anti-metabolites like mitomycin and 5-FU. These are used now. Other type of surgical options, these are non-penetrating surgery such as deep sclerectomy and viscocanatostomy. Okay, these are the two types of surgeries and they have a less chances of post-operative complications. Okay, now the next topic, primary angle closure glaucoma. Okay, primary angle closure glaucoma, and it is also called as acute conjunctive glaucoma. Okay, acute congestive glaucoma, primary angle closure glaucoma. There it was chronic, and here it is acute conjunctive glaucoma. It is acute, so it will happen in a sudden action, like approximately 20 to 40 years of age, most commonly in young adults. Okay, now what is the mechanism for PAGG? So there is a relative pupillary block. Okay, so apposition of pupillary margin against the lens surface in the mid dilation. Okay, so there is an opposition of pupillary margin against the lens surface in a mid dilation, that is approximately 3.5 to 6 mm. Okay, then aqueous cannot flow from the PC and to AC. Okay, so the aqueous get obstructed, it cannot flow from the PC to the AC, posterior chamber to the anterior chamber. Okay, this leads to iridotrabeculocorneal content and ultimately PACG. Now what are the risk factors and classification associated with PACG? The risk factors are hypermetropia, small axis length, small cornea, okay, shadow anterior chamber is seen in females, it is commonly seen in females, okay, and plateau iris is seen. All of these factors are precipitated by in the dim light. Remember this, all of these factors are precipitated in dim light. Atropine is contraindicated in PACG, very important, okay, because it is used for dilation of the pupil, atropine, and it is contraindicated in these cases. Now, what are the classifications of PACG? So, first, PACG, primary angle closure suspect, that is, in this there is a normal intraocular pressure, normal optic disc, but opposition, there is a opposition within more than three quadrants, okay, within more than three quadrants, and ITC cataract is seen, okay. The next classification includes PAC, primary angle closure, okay, there is an increased intraocular pressure, optic disc is again normal, and there is a peripheral anterior synecdoche present, okay, so the peripheral anterior synecdoche is present over here. Now PACG, another classification for it. Now optic disc and visual field changes are present over here, okay. What are the clinical features for PACG? Headache, the common symptoms between both. Now there is a loss of loss, or there is a blurred vision. There is a pain in eye, and that is the severe pain over here. There it was a normal pain. Nausea and vomiting is seen over here. Redness, inflammation is seen over here. There is a formation of halos around light. Okay, so halos are being formed over here. Now halos can also be seen in, what are the other conditions in which halos can be seen in? So these are mucopurulent conjunctivitis, okay, cataract as we studied, and now PACG. These are the three conditions in which you can see halo formation. Now to differentiate between the cataract and PACG, okay, to differentiate between both of these, we use a Flenkemp's test, okay. Flenkemp test is used by stenopatic slits, okay, so these types of slits are over here. So if the halos are appearing broken, then that is a cataract over here. If the halos are intact, they are not broken over here, then this is a PACG. So this is a differential method by which we can differentiate cataract and PACG, okay. Now PACG is diagnosis of exclusion, okay, that you have to remember. Now what are the signs of PACG? That is the most important part. And there is an increase in intraocular pressure, and it becomes more than 40 mmHg, and it causes severe pain in the eye, okay, as we studied, severe pain in the eye is seen. On digital tonometry, okay, on palpating by your fingers, there would be a rock hard eye due to this increased intraocular pressure. We have studied this. On torchlight test, there would be a elliptic sign, okay, this also we have studied. And the pupil vertical oval, okay, pupil is vertically oval, and it is mid dilated, it is fixed, and it is due to posterior synecdoche formation, okay. So pupil is vertically oval, it is mid dilated, and it is fixed due to posterior synecdoche. You can see in the image there is a redness, inflammation over here, there would be a severe pain. There is a mild dilation of pupil, as you can see in this. Okay. Now, what is the treatment for PACG? In acute cases, it is immediate reduction in the intraocular pressure. Okay. The drug of choice for acute PACG, ACG, it is IV 25% mannitol over 30 minutes. Okay, over 30 minutes we have to use IV 25% mannitol, or you can use acetazolamide 250 mg tablet for 2 times. Okay, the drug of choice for ACG, PACG, that is pilocarpine. Okay, that is used for miotic agent, and it pulls the iris away from the angle. That is the mechanism of action. Okay, what is the treatment of choice? The treatment of choice is laser iridotomy. Okay, and that is used between the 11 o'clock and 12 o'clock. What is this 11 o'clock or 12 o'clock? So basically at the 11 o'clock and the 12 o'clock position, we are going to do the surgery. Okay, so this image tells you about that. So that was all about the topic in the glaucoma. The next topic will be secondary glaucoma and congenital glaucoma.